Just doing another quick audio check. Can everybody hear me okay? If you could just, great, thank you. Just wanted to, I don't know if you could see this, but um, the quick poll in the beginning, I just asked, have you recently had trouble getting Plaquenil? And it looks like about a quarter of you have out of 11. So we know that's still kind of an issue. Well, thanks again for joining me on a breezy and cool Sunday night. I hope you're warm and secure wherever you are, and I appreciate you meeting up like this. It's really become a part of my week, and I hope that this is helpful for you. And as long as it is, we'll be here for you. Want to thank all our supporters, especially the Lupus Foundation of America, Georgia chapter with Terry Iman, and all the great resources that they have. The Georgia Council on Lupus Education and Awareness with Chris Reed and Representative Kim Schofield, and the Goal Research Cohort at Emory University. I've actually stayed away from talking too much specifically about the virus because I'm not an immunologist or a infectious disease expert specifically in virology, but we're all becoming an expert in our own ways, and it sort of dawned on me that it's not good to not cover anything at all. But I do understand that there are better sources to go, and we can touch on that towards the end. But I heard a really good conference online from the National Academy of Sciences. It was amazing. These are the world experts in a variety of different fields, and they just give regular updates. So I thought I'd share some of the things that I've gleaned from it. And believe it or not, it's only been 120 days since we learned about COVID-19. I guess on some days I can believe it. On other days, I still don't believe that it's here. But in any case, it's been 4 months. And we're hearing about a lot of the numbers that are out there, and what is clear is that we knew that the numbers of people that are infected are lower than what is actually the infected numbers in reality, in large part because of the limitation in access to testing. But there's been a recent study this past week where in California, there was one kind of in the San Francisco, Stanford Bay Area, and then it was repeated somewhat in Los Angeles, in the county of Los Angeles. And they basically brought in X number of people from the population without being specifically targeted for COVID infection or symptoms. And they were tested for antibodies. And I'll go over this a little bit later as well. Bottom line is that the estimated numbers of people that were positive from the county were very underreporting what the antibodies are telling us, and by a measure of about 3 to 6 fold. So there are a lot of people out in the community, several times more than the numbers that we're hearing. And a lot of that is related to this huge period of infection that the virus has. From from the moment that someone gets infected by the virus, and at that moment you don't even know because you don't have any symptoms, what we call pre-symptomatic phase. And all the way obviously through the time that they are actively sick with the virus, that is a very long period of time, relatively speaking. It's 14 plus days. And that really is one of the devious ways that this virus has been so tricky for us, is that it has a very long period of time where people don't know they're sick, and there's the potential to infect someone. And there's a lot of virus in the nose and the throat and the lungs. It's a respiratory RNA virus, and it's highly infectious. It doesn't take very much of these viruses to infect someone if you touch a surface with a virus and then you touch your nose with it, for example. And as of now, we still don't have any treatments or vaccines are effective. And as it marches across the world, and it pretty much, as far as I know, every continent in the world except for Antarctica has been affected by COVID. But the stories are starting to come out in terms of these countries that are under-resourced compared to the US. And here we're talking about countries that are the wealthiest in the world having trouble staying on top of it. You can imagine how horrible it must be as it goes into parts of the world that are under-resourced. And even in the US, we're learning of this too, about how in wealthy countries, there are the marginalized populations, the rural areas that certainly don't have as much resources as the urban and suburban areas. And then we're learning about the disproportionate impact on the minority population that I've talked about in the past. And here are some recent numbers from the New York City Health Department, which really mirror numbers from other major cities, Boston. I haven't seen any directly from Atlanta, but I have no reason to doubt that this is not a universal phenomenon. And here, first of all, I'm going to focus on the African American population, and African Americans are about 13% of the US population. And here you see that in three main categories, you have those that are infected in general. So the large numbers are going to be not in the hospital. And then you have people that are in the second column here, hospitalized, but not fatal. And then, the far column on the right are the people who have passed away. In every one of these columns, you have the different groups, as you see here on the left. And these numbers that these bars represent are how many cases in each category per 100,000 people in the population. So forget about what 617 per 100,000 may mean in and of itself, but if you look at the relative figures, so in other words, African Americans compared to Caucasians, for example. So if African Americans only represent about 13% of the US population, with the majority being whites and then Hispanics and then Asians and other groups, but clearly the disproportionate load are on African Americans across all three categories. And it's something that people have a lot of ideas about, but we're still learning more as to what it may mean. And then you extend that into a condition like lupus, where there is also a disproportionate burden on minority communities. And then you add the fact that we're talking about an immunosuppressed condition, an autoimmune disease with medications that could potentially put people at higher risk for infections. And then you have all the associated medical conditions that can come with having lupus that you hear about in the general population with the COVID infections that put people at higher risk for complications. And that's hypertension, obesity, lung issues, heart disease, diabetes. So we're highly concerned about that. And we're certainly going to try to monitor that and see what it means for the lupus population. Lockdowns, what we are supposedly coming out of in Georgia, are not an exit strategy, meaning it's not a way of getting out of the issues with the pandemic, with people getting sick, social distancing, the measures that we have to take to protect ourselves. They merely buy us time so that the hospitals don't get overwhelmed. So they're there to save lives so that we are able to maintain some resources, like the ventilators for the worst cases. But that we're at least able to manage the numbers, and we have enough beds and have enough ventilators and have enough healthy healthcare professionals to take care of them. But obviously, it's a tricky balance because you're devastating the economy. You're having an impact on the general population in terms of mental health. And there's so many questions, and I hate being a broken record. It's weekly uh, accumulation of more questions than answers, but at some point that is going to start to change as we gain momentum on the scientific studies. But and these are just some other things that we are thinking about. And actually, before I go into the flu season, what happens during the summer? We don't know. And I thought we would get some sense of how the flu is doing in the southern hemisphere where they're going into the winter, but I don't think we have enough time for them to have had uh, the COVID virus in the southern hemisphere to and then build it up to the point going into the winter. So it's really us in the northern hemisphere that's going to learn a lot more about this. And so um, the summers, are they gonna is the heat gonna really slow it down? And some of the initial data that's out there doesn't seem to indicate that if it is going to slow down, it's not going to be a dramatic decrease. So any hope that this will really punch the gut of the virus in terms of the heat in the south, I mean, it still needs to be seen for sure as we get more numbers, but the early sense is that it's not going to be um, something that is really going to change the course of the virus over the summer. And then as we go into the winter next season, we have the flu season that comes back because all the other coronaviruses and other viruses are still around. And as everybody's been learning more about, is that the flu's been around. We took it for granted in a way, and it does a lot of damage too. And then when you couple the flu and corona, COVID, it's going to be potentially this double whammy that people fear. And I will say that early on in the Grady Emory ICUs, there's been about maybe 15%-ish of the people in the ICU that have had a co-infection, meaning they had COVID and another virus. Early on, about 4 months ago, we were at the trail end of the flu season, and so there was some co-infection of flu, but there were other types of viruses that are still around. So we're still going to have to keep our guard up for a while. But the world's faced a lot of challenges like this before, and so the question is, how do we do this cohesively? And that's going to be for some interesting times in the future. But I have a lot of hope because there's a lot of great people in the world, and a lot of smart people too, and passionate people. So this is the COVID cases around the country, and the larger the circle, the greater the number in that area. And you can see how New York has started out. I mean, it stands out as being still the hot spot in the United States. All this started out more in California on the West Coast, and it was mostly from cases that came directly from Asia. But interestingly, looking at DNA testing, and you can kind of see where um, mutations have occurred and where those mutations have come from. And they do this DNA sleuthing that's really amazing. They found out that most of the cases on the East Coast in the New York area have come from the virus out of Europe. Obviously, all of it came centrally, probably from the Wuhan area in China, but it went from there to Europe, and then to New York is where it didn't go from California to New York. The other thing I'll point out here is that Atlanta is not so small. I mean, it's not big either, which is great. And a lot of people are fearing that it may change, but kudos to everybody here, our neighbors, and just I think we feared so much worse, and that's what we should do. We should hope for the best, but plan for the worst, and we certainly plan for much worse, and it hasn't occurred yet. But the circle is not so small either, and everybody's concerned that with the relaxation around the state, that it may get bigger again for the second wave. But to everybody's credit, I think there's certainly people that are opening things up a lot more than others, and still a lot of places that are exercising more caution than anything else, and that's good news too. But we'll see. Nobody knows. There's a lot of speculation, and I really hope and pray that things don't get worse. The point of this slide is, I think one to point out that, as the cases in general on the left here have gone up, and you can kind of see that it's plateauing. This is across the US, but every area is very different. So one can look and hear about overall numbers, but the devil's in the details, and you have to look at what your particular area is doing. And so for us, it's in Georgia and Atlanta. But if you take overall numbers, there's some flattening, but don't take any solace in that, again, because there are some areas that are still going up, some areas, thankfully, that are going down, and everything in between. The other thing to point out here is that, and this gives you the sense of how the virus normally acts, it's delayed. There's that at least 14-day period where people aren't as sick, and then they become more sick after they get infected. So here you can kind of get a sense of that, in that the overall cases in the US looks like it flattens around March 30th, right here. And if you look over here at the deaths around March 30th, it's still going up. And that's because, again, that sort of 2-week lag. And you see that it still goes up here. There's an outlier here, I think, because of how an area in New York, they undercounted, and they just lumped everybody in at that point. But anyway, you can kind of see the deaths still kind of rising way after the point at which the reported cases have flattened out. And it's this delayed signal, if you will, that is behind people not really knowing what's going to happen with certain actions, like the state has in terms of opening up certain businesses. We're not going to know about the uptick in the ICUs for another 2 to 4 weeks from now. And so that's where we're going to keep an eye out for, and we'll see. This is the general testing, and how many tests in total have been done in the US, and thankfully it's going up, and it looks like it's starting to rise faster and faster, which is great. But again, we just don't have enough tests available. Some areas are better than others, and I'll tell you that Atlanta, or Georgia in general, is ranked in the bottom 10 of the states in terms of access to COVID testing for the general population. And that's something we desperately need to change quickly. And even though 4.9 million sounds a lot, it's still barely over 1% of the US population. So we certainly have a long way to go. But we're getting there. In terms of treatments being looked at, there's a lot. And you may have, remdesivir is a biologic agent that was designed for the previous SARS virus, and it's come back in terms of being tested for COVID. And there was some early results that kind of leaked out that gave some promise, and then I don't know if the company officially released the results, but they're definitely hedging the final numbers, is the last thing that I know. And some of you out there probably know better than I do, but there's caution, just like everything else. And that's certainly, we learned that from hydroxychloroquine. But it's still in the news, and there's still hope, but there's still no definitive information or data or conclusions coming out for remdesivir or for any other drug for that matter. Again, because we're barely 4 months into this pandemic, and these trials take some time to enroll, or to be designed, to be approved, to enroll, then to complete, and then to analyze, and then to conclude and publish the results. So we're barely in the, I mean, there's a lot of studies that are starting to recruit, which is lightning speed in the research world. But just to give you a sense, it's going to be several more weeks now. But people are going faster than I thought was even possible. There are other types of approaches, other ways to go at the virus and with using different mechanisms or different approaches with different medications. Some of you have probably heard about this convalescent plasma, where you get donors who have healed from COVID infection, who've recovered, and they've produced their own antibodies to the virus. And so the thought is to collect those antibodies from recovered COVID patients and pull them together and give them to somebody who is really sick. And again, there's just very anecdotal data, meaning stories here and there. And stories are okay. They give you a sense, and that's why you do the studies, because many stories have been refuted when the studies have been actually done. Because a story of somebody being sick, getting the plasma and getting better is a good story. But at the end of the day, it doesn't for sure tell you whether the plasma worked. Was it just the timing? Was it something else? There are other repurposed drugs, means drugs designed for something else that is being tried in COVID infections. And so everybody knows about Plaquenil or hydroxychloroquine. There's some HIV drugs that are being used as well in conjunction with other medications. There's a ways to do immune therapy and change your own immune response and boost it in certain ways, or change it in certain ways to make it better, perhaps, or theoretically, against a COVID infection. There are, we can make or design antibodies that we produce naturally ourselves, like this convalescent plasma, these antibodies to produce against the COVID virus, that for people who recovered from it. There, we have the technology to actually produce antibodies and create them in a certain way that it targets the COVID virus. So that's being designed. And so many other things in terms of treating somebody who's been infected. The holy grail really is vaccines, and this is to prevent someone from actually getting the infection by already priming the immune system. And so that if one were to get exposed to the COVID virus, you would be able to just wipe it out. You would have that extra boost of memory. And we know this from annual flu shots, the other immunizations that most of us have had growing up. And there are different ways to do it, and the science behind it is just amazing, but it is extremely sophisticated and not inherently slow, but just to give you an idea, I mean, not inherently fast. So it's a very slow process, but just to give you an idea, even though we're talking at least a year or so before a vaccine, just how amazing this effort is worldwide, that the SARS virus, which was about 17 years ago, back then, to go from sequencing, that is, knowing the exact RNA or DNA sequence that the virus has, the genetic fingerprint. And then from there, you can start working backwards and understanding better the design of the virus and then targeting vaccines. To go from the sequence of the DNA or RNA to the first humans that were injected with a potential vaccine, back in the SARS days, 17 years ago, it took almost 2 years even to get to the point of the first person being recruited into a clinical trial. And then you can see over time how that has really decreased. And here, the coronavirus, COVID-19, it was 2 months, lightning speed. So we are working, I mean, we, the scientific community, and the patient community, the volunteers who are bravely entering into these clinical trials, we're doing things that never have been done in history before, in part related to the speed of the development. And there's a lot of very interesting talk along this line of the talk that I was watching from the National Academy of Sciences that some of the press picked up was how there's a think tank, I forgot the name of the organization, but they focus specifically on virus and vaccine development. And they're proposing that even, I mean, to speed this process up even further, to start actually developing and the production of the vaccines even before the trials know fully whether it's safe or effective. And by that I mean, because it takes a while to start producing these vaccines. It's not as if you just start making a shot. There's a whole science behind producing these proteins, and you have to create a plant that will produce it in huge batches that are in a safe manner, in a clean manner, that you can distribute throughout the world. And so once you find a vaccine, you don't want another delay in terms of just getting it out into the real world. And so they're proposing that we start this process when we reasonably think that it may work without knowing for sure. And so that would involve billions of dollars of investment, and a lot of times that money is going to waste, in the sense that it's not going to, at the end of the day, they may say the vaccine is not as effective as we thought it was going to be early on. And all this effort to start producing it earlier, we're going to have to start over. And so, and that takes literally hundreds of millions and billions of dollars. But their rationale, which makes sense, is that if you could even get something that's safe and effective out into the world even a month earlier, then that in and of itself would save billions, hundreds of billions of dollars, just in terms of the economy and everything else. And so people are really being aggressive along these lines, and thoughtful and thinking outside the box. And people are countries are working together, and certainly our country it's doing its part as well. So we're in this phase of opening up America again, but there is a roadmap out there, and you see Dr. Fauci here on the bottom right. He's been kind of the spokesperson for the scientific and academic community, and he and a bunch of others. There's a lot of really good people on the task force and kind of working to get the solid scientific message across. But they've put together a roadmap, and it's a very slow roadmap. And that's the reality, is that in order to open up, you need to carefully meet certain goals. And to bypass or leapfrog a goal, it really sets you up for that classic take one step forward, two step back process. And I hope we don't take two steps back, because we are accelerating kind of this opening up. But again, I hope I'm proven wrong, and I really do hope that the second peak doesn't arrive as much as we fear. Okay, moving forward, there's some more additional Plaquenil news. I think this is the most recent. There is an FDA statement that cautioned against the use of Plaquenil or chloroquine for COVID-19 outside of a hospital setting or a clinical trial due to the risk of heart rhythm problems. And I'll say up front that this is not to scare anybody who's currently taking Plaquenil for their lupus, even if you have heart issues. So I'll explain why this is the case. Okay. I'm not 100% sure where the FDA got their data from this, because on their website, it just pretty much says that it was based on review of medical literature, their adverse event reporting system, some other databases, blah, blah, blah. So they weren't very specific, but I'm pretty sure that these studies had a fair impact on it. And we talked about this one last week. It's a study in Brazil where they used 2 different doses of chloroquine, not hydroxychloroquine, but a cousin of it, chloroquine, at 2 different doses, a higher dose and a lower dose. And everybody got azithromycin with it. And these are people with active COVID infections that were fairly sick. And they stopped the study early because in the high chloroquine group, and again, everybody's taking azithromycin, but in the high chloroquine group, 16 out of 41 people died, whereas 6 out of 40 people in the low chloroquine group died. So 16 out of 40 compared to 6 out of 40 was more than that would be just a statistical blip, kind of a random by chance, this group is a little higher than the other. And so that was stopped, and for good reason. But it really didn't mean that chloroquine didn't work. They just didn't have enough numbers to find out. They stopped for safety reasons. And I think I'll say it right here that the combination of chloroquine and probably hydroxychloroquine, because both chloroquine and hydroxychloroquine are known to have an impact on heart rhythms at much higher doses, and it's been given safely hundreds of millions of times throughout history, and many of you are on these medications, and we rarely even think about those issues except for some very special circumstances. But we were aware of these issues. But I think when you start combining it with azithromycin, another drug that has these irregular heart rhythm issues with it, that's one of the reasons, one of the lessons to be learned from this study is that you may want to be more cautious about combining the two. And then there's another study here that of hydroxychloroquine having no benefit. And this is the VA study. So if you hear about a VA study saying that there's no benefit, I think the better way of describing it is that the VA study did not support, did not give any more information that it is effective. I wouldn't say that it would definitively show that there was no benefit. And this study is what we call a retrospective study. They looked back to see, okay, who was on hydroxychloroquine, who was on hydroxychloroquine and azithromycin, and who was without either of those drugs with COVID positivity in the hospital at a VA facility in the past few months. Now, those different groups they're going to be different because people are going to either put somebody on hydroxychloroquine or not put them on hydroxychloroquine plus or minus azithromycin for different reasons. And maybe if someone is just sicker, they would have a greater chance of being on hydroxychloroquine because there was a lot of press at the time. There are no other treatments available. It was thought to be relatively safe. It's cheap. Most of the hospitals have plenty of supply at that time on hand. And so these are just really sicker patients who got hydroxychloroquine. And so it's much harder for that group to get better or look better compared to the other groups that they were looking at. So these, what we call retrospective studies, where you don't have people have an equal chance of going into one of those arms and being studied, you have to take with a big grain of salt. And that's why everybody talks about the gold standard, the best study to do is what we call a double-blind, placebo-controlled study, where nobody knows what group you're in, or at least a doctor who's treating you up front and you as the patient, for example. You just don't know what group you're in, and it's by chance, a computer flips a coin and puts you in one of those groups. And what that does is it kind of spreads out all these other factors equally into these groups. And so at the end of the day, if there's an improvement in one group, it's probably due to the only thing that's majorly different. That is either the treatment or not being on the treatment. And then the other thing to know is that as the FDA warning is again about these hospitalized people with active COVID infections. So these are really sick people with COVID infections. We're not talking lupus patients. So we're learning so many interesting things about COVID. And one of the things is its impact on the heart and the vascular system and the vessels. And we know that people with COVID already are predisposed to this heart arrhythmia, and they have other heart issues because of the COVID infection. And then you're adding Plaquenil into an already very highly vulnerable person. And then some of those people are on top of that taking azithromycin. And so I think that's where the Brazil study got in trouble and what the FDA is warning us about. So it shouldn't be taken as for you as someone who's been benefiting if you have been on Plaquenil for your lupus for a while and feel like you're benefiting from it. This is not addressed to you. But obviously, if you have any questions, you need to talk to your doctor about it. This is a study that you'll probably hear more about. Again, this is kind of along the lines of the retrospective study. You have to take it with a grain of salt. There's a big New York study where they're looking at, and any study out of New York makes waves because of the pure numbers that they have. And having a lot of people in a study, any kind of study, boosts it up a bit in terms of statistical power and things like that, that help us make, we come to a stronger conclusion. But it's not the perfect study if it's a retrospective study, which is what this is. And so someone leaked this is where we are in this COVID virus. We're talking a lot of early results, anecdotal or experiential type of stories, gossip and things like that in a way. So, these messages can get pretty hot, and you have to be careful about what you put your stake in. But someone did kind of leak out what they thought were early results from this New York City study, where again, it was retrospective, kind of like the VA study. I still wouldn't put that much stock in it, but their conclusion was hydroxychloroquine did not show a strong effect in terms of improving people on it. No one's really seen the results. And from what I understand, that the results have been sent to the CDC and the White House, and they're supposed to be reevaluated and then more publicly announced. I think it was supposed to be earlier this past week, but it's going to be this week. So if it maybe has gone out and I'm just a little behind, but if it hasn't, it's supposed to come out pretty soon. I'm sure you're going to hear a lot of press about it. And if it is a negative study, meaning it did not show any impact of hydroxychloroquine, just take into account that it's a retrospective design, that I know, and it was just looking backwards in time into these groups that, again, are subject to people putting people on Plaquenil for certain reasons. And so there's only so much conclusion you can take from that. So where are we with these good studies that are going to supposedly give us stronger conclusions? And excuse me, there are a lot going on. And like I said, we're barely 4 months into this, and we're just starting a lot of these studies. And if you're ever curious, I don't know if you know about this resource. It's called clinicaltrials.gov, but it's a worldwide database, and I think almost it's pretty much worldwide, accepted worldwide. But for all the major scientific journals, and that's what every scientist that and researchers that's doing this type of research, any kind of legitimacy to the results is going to be after it's reviewed in one of these journals, accepted and published. And the only way you can get these, you have to, by requirement, in order to get a study published, have it put into this database, clinicaltrials.gov, before it even gets started. So you will see studies from the very beginning, and many of these studies won't finish or will become negative. I mean, regardless of the result, every study that has been thought of, that is put in, it gets put into this registry. And right now, I mean, as of this morning, when I looked at hydroxychloroquine and COVID studies, there were 133 studies worldwide. About 75 are actively recruiting, meaning they are looking for people to go into their studies, either publicly or enrolling by invitation, or they've completed their enrollment and they're actively following the people, seeing, getting more data before they close the study and analyze the final results. So 75 are still up and going out of these 133, and 54 are not yet recruiting, meaning they've been designed and they have no patients in there yet. So a lot more results to come and more information. Here's a question. You mentioned a few weeks ago a lupus patient that tested positive for COVID-19. Can you tell us what were their symptoms? Were they hospitalized? If so, for how long? Did they have to be intubated? What medications and treatments did they receive to recover? And were they previously on Plaquenil? I think in a way, for patient privacy, I'm not, in part, I can't reveal any more detail, but I'm not going to anyway. And I think one of the intents behind this is to just get a sense for some people. I'm not saying for the person who necessarily wrote this question, but maybe for some people, they want to know out of this one lesson, if you will, what is their risk or what could they do, or if someone maybe that they know, one person is just, that's where these stories, as interesting as they are, they can be very misleading and sometimes dangerous in a sense if you put too much stock in them. I think I did reveal in the very beginning that this person was on Plaquenil around the time that they were diagnosed. There's certainly other people with lupus on Plaquenil that have been diagnosed, and others who weren't on Plaquenil that were diagnosed with COVID. And there's so many caveats behind that. Even if Plaquenil is effective, maybe some people weren't taking it regularly at the time. Also keep in mind, as you all know better than anyone, everyone's lupus is different. Can you say that if Plaquenil does work, and that's a big if, is it going to work the same in someone that has some relatively mild skin issues, a positive ANA, but overall generally doing well, compared to someone who has active nephritis that's been on Cytoxan and is now on rituximab, as well as 20 milligrams of prednisone and Plaquenil and azathioprine recently, but switched over to mycophenolate or Cellcept, and all of these other medications are immunosuppressive and counteracting everything that the Plaquenil may or may not be doing. So these are all the many, many caveats that have to be carefully considered. And again, these stories, whatever you read on the internet or you may hear from others, it just cannot begin to untangle those issues. And um, again, we just have to wait on that. So apart from this one patient, I can tell you that all of these different issues have been seen both positively and negatively in other people with lupus that were positive for COVID. So there were some people with lupus that are intubated, some that were not, some that were on Plaquenil, some that were not. So these are two questions that kind of touch at the next phase, kind of what we talked about last week. I work in a school. What should I do if we do indeed return in the fall? And then should a person with lupus return to work as soon as their office opens? And if not, do they need a doctor's letter? What should they do? Specific to the school, it'll be interesting to see what happens. I mean, I can barely predict what's going to happen tomorrow. But I do know that the infectious issue with COVID is going to be around until the vaccine is fully in place. And so we're talking a year to 2 years where we're going to be always confronted with the fact that there is no solid defense, and there are people going to be around that are infectious. And so a school is interesting in the sense that you have children involved, and some people had advocated, and I think it's like one of the celebrities, Mr. Phil or somebody, or maybe Dr. Oz. I mean, they were talking about, I think it was Dr. Oz, like having to open up the schools again. There aren't many kids that have gotten it infected or certainly died with COVID. And relative to the adults, it's true. I mean, thank goodness that the children don't get COVID infection as much as adults that give them severe complications. But there have been some recent reports of some very young children that have had some very bad results. But as a whole, you don't hear the numbers that you do in adults. But that's in terms of complications, and their immune system is such that, and the virus is such that if they do get infected, again, thankfully they don't get us sick, but they're still infected, and they become the carriers to then take it back home and to their parents or to their grandparents. And so that really is the bigger point that's lost in that discussion. And so, that's one thing to consider. And then, children are they going to be able to practice social distancing effectively and maintain the sanitation practices? And I guess a lot depends on the age, but just like adults, there are some people that are older that you just are not going to be able to train that well or adhere to some of the rules. So for the person that's going, that may eventually go back to work in the school, it really is just like everyone else. You're going into an environment that is potentially infectious. And so I'll kind of roll this into the second question about, so let's say whether it's a school or an office, and you need to go back into the workforce to put food on your table, that you just need to go out into the public. And that time eventually is going to come, because over the next 2 years, for many people, can you just isolate yourself without going outside or going to work? I think for a lot of people, that's not going to be an option. So you're going to have to be confronted with this. And I don't have specific formula for you in terms of what exactly you need to do, but I have some basic requirements, and that is you need to be as protected as possible. And I mentioned this the last week or two, that until it's proven otherwise, there's every reason to believe that people with lupus, again, because of the immune issues and the medications that you're on, you're going to be at higher risk. And that is not going to change in the near future at all. So you are going to be very obviously marked as a high-risk individual, and hopefully that will be to your favor in the sense of work accommodations. You're going to absolutely should have some clarity as to how to minimize the risks to you that are probably at a higher level than the average person. Now, everybody is going to need some level of security in minimizing the risk to that individual, and exposure to other people, exposure to surfaces that may not be clean. But how much more in terms of someone with lupus, there's no clear thing. It's just that you need to make sure that you go back into a situation where you feel comfortable with what's around you, and you need to discuss that with your doctor, given the type of medications that you're on, the type of occupation that you have, the frequency and the type of exposure that you may have to other individuals will really determine that. And you're going to need what you're going to need, and it should be there. And so if you are around a lot of individuals, you're going to have access to good face masks that are available to you, and clean ones that are good, and access to sanitizing equipment for things around you, and a distance to be able to say that I can do my job, but the person doesn't have to be 4 feet away from me. They can be 8 or 10 feet away from me by using this way. You should be proactive and provide feedback, and be creative, and say, why not do this? We can put up this barrier that's see-through, and I can hand things around it, or they can go pick it up if I put it over there. You have to be really an advocate for yourself, and you guys are not strangers to that. But hopefully we will have this sensitized to the employers out there, and that there are safety nets in terms of the laws and the guidelines that dictate what employers have to do in terms of work safety. And I'm sure that will come about. Hopefully it'll be strong enough, but that is something that we're going to have to really band together through organizations like the Lupus Foundation to make sure that the Occupation and Safety Hazards Administration, Health Administration, really helps protect us in that regard. Now, in terms of other things that we could do, the doctor's letter, employers treat letters from doctors so differently. I think some may, I can see some employers wanting to have like a medical clearance if they know that you have some immune condition, that you're able to safely go back to work. And that may be a good chance to get a letter from the doctor saying specifically that you need extra protections, or that it's highly important for that you have access to X, Y, and Z. And you need to work with your doctor to craft a good letter in that regard. And that may be something to work on, Terry, in terms of some resources down the road, or maybe the national office should think along these lines about how best to be prepared to go back into the workplace, and having sort of draft letters that you can give to your doctor. And that helps me a lot too, actually, is to have a letter drafted. I personally have never found offense to that. I think it's great. At least I know what your expectations are. I may not sign it verbatim, but it is good that I have something to work off of. And as busy as everybody is, but especially doctors, as you know, it's great to give them a head start by drafting something. What's the difference between the testing they're doing now for COVID and antigen testing? So I just wanted to be clear about a couple things. I think you meant antigen versus antibody testing. So I found this graphic online. The test to see whether you have the virus that is in your body, basically, are you infectious, whether you have the symptoms or not. Uh, that's what we call antigen testing. And that is what you see people getting swabbed for. And because this is a respiratory virus, the virus is going to be very heavily concentrated in the respiratory tract, starting from your nose into your lungs. So inside of your nose, the back of your throat, and into the lungs, if you can get a swab there. And the easiest way to do it is the most reliable way is both the nose and the throat. And they're doing it differently for different tests, but anything that swabs those areas is an antigen test. And that's looking whether to see if you have the virus and you're infectious. And what that does is it collects the virus that has an RNA sequence in it. This is an RNA virus. It creates a template to basically multiply it in a device called a PCR machine, and it creates a ton of this RNA so that it can be easily detected with what we call fluorescent dye. It lights up, and so that's the way that we detect active virus. So that's an antigen test, and it's a swab. Now the antibody test is something that's getting a lot of press now, and that's a blood test, and that detects whether you had an earlier infection. It could be relatively recently, or it could be weeks afterwards. So this is something that has been helpful to kind of get a sense of who's been exposed in a certain group to the infection at any given point in the past. And just to kind of give you a sense of what the antibody tests do is that the antibodies come in two different flavors, IgM and IgG. And if you get infected here at minus 14 days, so it takes about like 2 weeks or so, or 14 days to develop clinical symptoms. And so when you start developing symptoms, you usually get infected for about 14 to 21 days. And so the first type of antibody that in any infection that people develop is what we call an IgM. And so that goes up and then starts going down, and that goes away in about a month or so completely, but it starts getting pretty low within about 2 or 3 weeks. The IgG is what sticks around for a long period of time, and that will be there for at least a month or two plus afterwards. And these are the antibodies that we talk about that may be giving us hopefully some level of protection. This is what a lot of vaccines do, is they give your body the ability to produce these antibodies the next time you get exposed to the infection in a more effective manner. So every year when hopefully most of you get your flu shots, it's teaching your body to produce these IgM and IgG responses much more quickly and effectively. But the other big question that you may be hearing about is whether these antibodies are truly for COVID are giving us protection. And again, another one of these huge mysteries of the virus, again, understanding we only have 4 months history, really, and even really less than that in terms of good early scientific information, but very short period of time of being confronted with this virus. And this is what they call a novel virus. It's new to the human species, and every virus can be slightly different in some way. And it's not really clear whether someone who's been infected before that's developed these antibodies have strong protection against being infected again. And so it is a little unsettling in that regard, but that possibility, but we just don't know yet. So we need more information, and that's going on right now. So I'm about to end here. What's the best way to get reliable information about the virus and lupus? There are friends that are more reliable than others, right? Just like in real life. And the friends in the scientific space when it comes to living with lupus, and we start with the Lupus Foundation of America, And then everything else that you've been reading about and hearing about, these huge organizations, CDC, the WHO, the World Health Organization, you have the Georgia Department of Public Health, you have sites at Emory University and Augusta University. And so these are trusted organizations, but, and you should still go to that. But I think even for myself, it is tough to synthesize all of this information from all these different sites. And I just listed, what, 6, 7 different sites. And when you go to them, it can be overwhelming, the amount of information that they have. And sometimes you just want a nugget. Is this good or not? What is my take-home information? Should I do this or not? Should I feel safe about this or not? And I think maybe what the intent behind that question is, it's these sites are not going to give you that nugget sometimes. Because they are the trusted sites, they will more often than not give you what they're most comfortable in sharing, and the information that they have that's known publicly, that they know. They don't, the last thing they want is to give you something in error, or else they don't become a trusted site. So it's good to go there for the information that we know with a reasonable amount of certainty that is true, or they'll tell you what we don't know. And so those are great places for that. But I think that's the space that a lot of people are missing, is a lot of these practical questions that you were throwing to me and others every week and every day. And the bottom line is that for the most part, we just don't know the answers to so much of this yet. And it's hard for me to say this, but it is true. And but that is an opportunity for a lot of people to pontificate and to guess, and potentially steer people in some directions that may or may not turn out to be true. And if it's not true, it could potentially even harm people. And how do you know when that's going to happen or not? It's tough to say. Even things in the press, the general press, or some people will say trusted press, whether you're a Fox person or a New York Times or a CNN. I mean, every one of those news organizations where I go to a lot, you always have to take things with a grain of salt and look at where they're getting their information from. See if you can find other places that not only just say the same thing, but in a different way. But maybe if you find other sources that provide other supporting information to come to that same conclusion, and eventually you go back that some of the supporting information do come from some of these trusted sites like the WHO, the CDC. I mean, that's when it becomes more credible. But I wish I could tell you that there's a website called trustedlupusinformation.org, where related to COVID, this is where you go to end all and be all of everything. And this is where this virtual town hall, I think, plays some role. Not that in a way, I feel like I have a bully pulpit here, and I hope, I want to maintain some humility. I mean, a lot of humility. I said in the beginning, but it's worth repeating again, that you should always double check what I'm telling you. But I just want to be one piece of the many pieces of information that you use to then kind of paint a picture of, not only is it being said a lot, and that's part of what you should look for, like, is it being said a lot by a lot of trusted sources? But even more than that, think about, well, why are they saying it a lot? Where is this information coming from? What type of study is it? And this is where I'm trying to fill in some of the gaps and saying, well, retrospective studies are not the best. You really have to be careful about it. These double-blind, placebo-controlled studies are the best, but they take longer, and they're on its way. And as these results start coming back, I'll do my best to give you some summary of them, even after I start doing that, I want you to do your homework too and just keep going around. I wish I had a better answer to that. But please, let's work together as a community. I mean, we're here to inform each other. Sometimes we can agree to disagree, but at least we're here to walk together and struggle together and share information, and that's what this forum is for. So continue to check the lupusga.org website. Continue, please, sending your information to info@lfaga.org. We want this to be a place to better serve you and provide information. And I see Terry is already kind of giving you a link regarding accommodation and compliance information. So she'll put that on the website. I'm sure it's already there even. We're going to point these things out. Terry is also going to put a link for a survey. It's really quick. I mean, it's literally, I mean, it can be a few seconds, upwards to like 30 seconds, but it's just basically asking for your feedback about this. What can we do better? How can we make this more effective in terms of equipping you to live with lupus? And so she has a link up there. It'll also be on the website. So in this recording afterwards. So if you miss it, don't worry about it. Look for it on the website. We'll keep bringing it up in the weeks to come so that we get more feedback. And boy, I went really long today, but you know, sometimes you feel like it and other times you don't. I'm going to end with this. This is a joke. This is a satire. So don't, you know, take this as gospel, but you know, this is along the lines of where do you get solid information? And this is just a parody, right? But you know, there is a grain of some truths in here, just like any satire. So Dr. Oz is part of the problem, not the solution. The CDC revised new guidelines this week that include a duct tape mask for Dr. Oz to wear. These new guidelines should have been in place years ago. We're hoping to significantly slow down the spread of false information by this duct tape mask to keep him from talking. He's a cardiothoracic surgeon. Before he became a television personality, now offers his expertise on the coronavirus and the economy. Each on their own would take years to master, but he has read a couple of studies and now in a position to advise policymakers and the public. I'm not personally trying to attack him, but all this is to say, I mean, you can put in place of Dr. Oz many other names, and I'm sure he has very interesting things to say about a lot of other things. And he is a physician. I've never really heard his show, but the point is that every source, including me, including this virtual town hall, you need to band together, share information, and really put people to the test. Ask why and where they got the information. And, you know, we can be wrong too. And so with that, I'm going to end. And for those of you who stayed this long, thank you for sticking around. And I hope you stay warm tonight. And I look forward to seeing you again next week. Good night.